Let's see about esophageal carcinoma. There are two morphological types of esophageal carcinoma. They are, one is squamous cell carcinoma and the other is adenocarcinoma. First, let's see about the squamous cell carcinoma esophagus. The squamous cell carcinoma is a malignant neoplasm of the esophagus showing squamous differentiation. That is why this is called as squamous cell carcinoma. This is most common in males and above 45 years of age. Coming to the etiology of squamous cell carcinoma, risk factors. The risk factors include high alcohol intake, tobacco smoking, poverty and vitamin deficient diet, consuming burning hot beverages very frequently, and other risk factors include Plummer-Vinson syndrome, achalasia cardia, celiac disease, and human papillomavirus infection in high risk areas. Next is the morphology. First, let's see about the gross. Most common location of squamous cell carcinoma esophagus is the middle one-third of esophagus. Coming to the patterns of growth. There are three different patterns of squamous cell carcinoma esophagus. First is fungating or exophytic. In this case, the tumor protrudes into the lumen and it obstructs the lumen. So this is the esophagus and this is the fungating grey-white tumor which protrudes and obstructs the lumen. The next pattern is ulcerative squamous cell carcinoma esophagus. Here there is growth with elevated ulcer edges. So this is the esophagus and this is the ulcerating grey-white tumor. The third pattern is infiltrating or stenotic squamous cell carcinoma esophagus. This is less common and it is predominantly intramural. In this case, this is the esophagus and this is the infiltrating or stenotic pattern of squamous cell carcinoma. Here there is infiltrating grey-white tumor. Coming to the microscopy. In microscopy, there are malignant squamous cells with varying degree of differentiation and the presence of keratin pearls which are eosinophilic material like these. Eosinophilic acellular material arranged in whorls like these keratin pearls. Also there is keratinization of individual cells and presence of intercellular bridges. This is the microscopic picture. Next, coming to the spread. Local spread is to the respiratory tree, aorta, mediastinum and the pericardium. The lymphatic spread is different at different sites of carcinoma. First, carcinoma in upper one-third of esophagus spreads through the lymphatics to the cervical lymph nodes, and carcinoma in the middle one-third of esophagus spreads to the mediastinal, paratracheal and tracheobronchial lymph nodes, and the carcinoma in the lower one-third of esophagus spreads to the gastric and the celiac lymph nodes. Next is the hematogenous spread. Hematogenous spread is to the liver, lungs, adrenal, kidney and the bone. Next, the clinical features of squamous cell carcinoma esophagus. It is insidious in onset. The symptoms include dysphagia, difficulty in swallowing, odynophagia, pain during swallowing and obstruction. These are the clinical features which are insidious in onset. Now coming to the next type, Adenocarcinoma esophagus. Adenocarcinoma is a carcinoma with glandular differentiation, and it usually arises in a background of Barrett's esophagus and long-standing gastroesophageal reflux disease. The etiology. Risk factors include dysplasia, tobacco use, obesity, and prior radiation therapy. Also, the risk is decreased by consuming diet rich in fresh fruits and vegetables. Next is pathogenesis. The genetic changes involved include mutation of P53, which is a tumor suppressor gene, amplification of ERBB2, cyclin D1 and cyclin E genes. Next, the epigenetic changes. This include silencing by hypermethylation of P16 or INK4A. Next, the morphology. First is gross. Site involved. Usually, it involves the distal 1/3 of the esophagus. And appearance. The early lesions appear flat or raised patches. Later, they become infiltrative, diffusely, or ulcerate. So, initially, they are flat or raised patches, which then infiltrate diffusely, or they may even ulcerate. Next is the microscopy. In microscopy, there are malignant tumor cells with intestinal type morphology of cells forming glands. Most commonly, the tumors produce mucin as they have the goblet cells. Next is the clinical features of adenocarcinoma esophagus. The clinical features include pain or difficulty in swallowing. Pain on swallowing is odenophagia. Difficulty in swallowing is dysphagia. The other clinical features include chest pain, progressive weight loss, hematemesis, that is blood vomiting, or vomiting. So this is all about the esophageal cancer. Thank you.